Quick confession, during my own series audit, I realized we never did orbits. Today, we're fixing that. Clean, fast, and board safe. If you've ever fought Petrus ridges or chased the optic canal around an orbit, this one's going to feel like a deep breath. By the end of this video, you'll be able to 1. Park the Petrus ridges exactly where you want them in Caldwell and Waters. 2. Pick the right view for blowouts versus foreign bodies. And 3. Put the optic canal in the lower outer quadrant on Reese, on purpose, not by luck. Quick tip before we dive in. You can jump to any topic in my CQR study outline in seconds. Open the doc, press Ctrl F on Windows or Command F on Mac, and type what you want. We're going to type magnification mode. See how it jumps to fluoroscopy fundamentals at 9 minutes and 33 seconds? Click the timestamp to go straight to that moment in the video. Type grid conversion. That lands on the image quality episode at 10 minutes and 40 seconds. Perfect when you need Bucky factors fast. If you're cramming between cases, Control or Command F is your superpower. And yes, orbit timestamps are getting added to the outline after this upload. Until then, use this search trick to jump anywhere you need. Let's roll. All right, 30-second anatomy flyover. Each orbit is a pyramid, base at the front, apex at the back, 4 walls you should hear in your head when you position: roof, floor, medial wall, lateral wall. The orbit is built from 7 bones: frontal, zygomatic, axilla, lacrimal, ethmoid, sphenoid, and a tiny sliver of palatine. What matters clinically? The orbital floor, hello blowout fractures, the inferior orbital rim, the optic canal for Raymond at the apex, and the maxillary sinus sitting just below the floor. Trauma, look for the teardrop sign hanging into the maxillary sinus, step-offs at the inferior rim, and floor asymmetry compared side to side. Here's a quick safety moment before we shoot orbits. First, collimate tight and choose PA when you can. If a PA, like Caldwell or Waters, answers the clinical question, use it. PA lowers lens dose compared with AP. Collimate just to the orbits, use a short exposure time, and coach the patient. Stare at one spot, don't chase the light. Blink between pictures if you need to. Always rule out metal first. Ask 3 quick questions. Any grinding, welding, hammering? Have you ever had a metal speck in your eye? Any eye surgery or implants? If there's any chance of metal, confirm an orbital foreign body check before other views and keep exposure to the minimum. Remove glasses, metal magnetic lashes, nose rings near the field, and glittery makeup. Document what you found and flag the radiologist. There's no MRI for this patient until cleared. The bottom line, use PA when possible, tiny field, minimal repeats. ARRT always. All right, here's what we're going to be covering today. The PA Caldwell for global orbit assessment and Petrus placement, the Waters and modified Waters for the orbital floor and blowout suspicion, and a true lateral for foreign body and soft tissue. Lastly, the Reese, the parieto-orbital oblique, to land the optic canal where boards expect it. First up, our PA Caldwell. The patient faces the receptor, forehead and nose on the IR. Make the OML perpendicular to the IR. Center the CR to the Nazian. You've got 2 Caldwell flavors for orbits. 15 degrees caudad, or down to the toes, is the classic Caldwell. This puts your Petrus ridges in the lower third of the orbits. 25 to 30 degrees caudad is the orbit-friendly Caldwell. This drops the Petrus ridges below the orbital floors so the orbits are clean. Your patient cue sounds something like this. Gently rest your forehead and nose on the board. Keep both eyes looking straight ahead. Hold very still. Don't blink if you can help it. Take a short breath in and out and hold your breath. Here's some technique pearls. The typical starting point is 70 to 80 kVp. Use a small focal spot, grid per your department policy, a 40-inch SID, short exposure time to fight the blink or motion. AEC center cell if your department allows, but manual technique is fine. So what do we want to see? Orbit symmetric, no rotation, and depending on your angle, the petrous ridges should be either in the lower third if you shot at a 15 degrees caudad, or the petrous ridges should be completely below the orbital floors if you used a 25 to 30 degrees caudad. Fast fixes. If your petrous ridges are too high, add a little bit more caudal angle or re-square the OML. If your petrous ridges are too low, back off a few degrees. Head rotated, reset the inner orbital line parallel to the horizontal edge and recenter. Next up, our Waters Parieto-Caldwell View. Extend the patient's neck so the MML is perpendicular to the IR. That places the OML 37 degrees off the detector. The CR is perpendicular, exiting at the acanthion. Your technique. Start around 70 to 80 kVp with a small focal spot for detail. Use a grid and short exposure time. This is your first line view for the orbital floor. In blowout fractures, you're hunting for the teardrop sign hanging in the maxillary sinus. An inferior rim step off. Floor asymmetry, left versus right. When you're spot on, the petrous ridges lie just below the maxillary sinus floor, so they're not obscuring the floor. Here's your patient cue. Lift your chin like you're smelling a flower. Keep your mouth closed, eyes looking forward, hold perfectly still, no blinking if you can help it, short breath in and out, and hold. Here's some pitfalls and fixes. Petrous ridges creeping up into the maxillary sinuses. You need more extension. Recheck that MML is truly perpendicular. Mid-face looks stretched. You overextended. Ease off a touch. Modified Waters tweaks the angle for finer floor and rim detail. Reduce the extension so the OML is about 55 degrees to the IR. The MML is not perpendicular here. CR is still perpendicular to the acanthion. So why do we use this view? This variation projects the orbital floor and inferior rim with cleaner separation. It's great for subtle floor defects or rim irregularities that get muddy on standard waters. You still want the petrous below the maxillary floor. If they're creeping up, a hair more extension to reopen the floor. On the lateral view, the side of interest is next to the IR. Make the IPL perpendicular to the IR and the IOML parallel to the floor. The CR is perpendicular, centered to the outer canthus. This is your foreign body screening view and your soft tissue view. Consider slightly lower kVp if your protocol allows to emphasize soft tissue contrast. Use a small focal spot, tight collimation, shortest time you can. If foreign body is suspected, keep dose minimal and verify with the radiologist about further views or CT. When you're dialed in, the orbital roofs are superimposed and the sella and mandibular rami line up, no rotation, no tilt. All right, here's some pitfalls and fixes. If you have double-decked orbital roofs, that's rotation. Re-square the face. If you have uneven cranial base, that's tilt. Adjust the head height until the IPL is perfectly perpendicular. Lastly, the Reese, the parieto-orbital oblique, the optic canal target. Why boards love it? The Reese is one that trips people up. The goal is simple. Put the optic canal foramen in the lower outer quadrant of the orbit. Say it out loud. Lower outer quadrant. Start from a PA orientation. Rotate the head about 37 degrees towards the affected side until the chin, cheek, and nose all contact the IR. Now adjust the AML, that's the mentum, to the EAM, so it's perpendicular to the IR. The CR goes through the affected orbit. Your patient cue would sound something like this. Rotate your face towards the board until your chin, cheek, and tip of your nose all touch. Tiny chin tuck, good. Don't blink, hold that, short breath in, out, and hold. When you've nailed this view, the optic canal is a small bright circle sitting in the lower outer quadrant of the orbit. Not center, not upper, lower outer. Here's some misses and micro corrections. Is the canal too medial? You under rotated, rotate a touch more towards the affected side. Is it too lateral? You over rotated, come back a little. Too superior? You tuck the chin too much. Re-square the AML perpendicular to the IR. Too inferior? Lift the chin slightly to restore AML. Bilateral tip. Do both sides for symmetry when requested. Keep your rotation consistent and only flip which orbit you center. You want to use a small focal spot, tight collimation, short time. If AEC is used on your system, be sure your cell selection won't chase the dense petrous. Manual often gives more control on this view. For a suspected blowout fracture, start with the waters and modified waters. Add a lateral if swelling is substantial. Look for the teardrop, inferior rim step-off, and floor asymmetry. For metallic intraorbital foreign body screening, lateral plus Caldwell or waters per your protocol. Ask about exposure to metalwork, grinding, hammering, machining, and keep exposure minimal. If there's any doubt, escalate per policy. Often CT is the definitive study, and MRI is contraindicated until metal is ruled out. All right, here's some common errors and fast fixes. On the Caldwell, if the petrous ridges are too high, add a caudal angle and re-square to the OML. If the petrous ridges are too low, reduce the caudal angle. If there's rotation, recenter to the Nazian and align interorbital line. On your waters or modified waters, if your petrous ridges are crossing into the maxillary floor, increase extension. If you have overextension, distortion, ease off the neck extension. On a lateral, if you have double orbital roofs, you need to correct your rotation. If you have an uneven base, you need to correct the tilt. On the Reese, if the canal is not in the lower outer, recheck your 37-degree rotation and that the AML is perpendicular to the IR. Micro-adjust the chin and rotation 2 to 3 degrees at a time. Your technique starting points. Always follow your site protocols. Your KVP for all of these views is typically between 70 and 80 KVP for facial bones, orbits with a grid. You can go a little bit lower without a grid for lateral soft tissue if allowed. Your SID is 40 inches for all of these, and you're using a small focal spot whenever possible for detail. Usually we want to use a grid for the Caldwell and waters, modified waters, and Reese. The lateral may vary by body habitus and protocol. If you use it, choose a cell that actually sits under your anatomy of interest. Otherwise, go manual to prevent the system from compensating for petrous density. Motion. You want to keep exposure time short. Remind the patient not to blink during the exposure. All right, let's wrap this up with a little quiz. All right, first question. What's the best first view for suspected orbital floor blowout? Answer in the comments. Question 2. On Reese, where should the optic canal appear? And question 3. In a Caldwell for orbits, which angle places the petrous in the lower third of the orbits? All right, that wraps up our orbit series. Don't forget to check out my CQR outline. If I missed anything, let me know in the comments. The next thing we're going to cover is pelvis and hip. If this helped you, hit like, subscribe, and share it with a classmate who still mixes up waters and modified waters. And don't forget, open the CQR study outline, use those timestamps, and press Control or Command F to jump anywhere in seconds. You've got this. Keep your collimation tight, your markers visible, and your petrous ridges exactly where you want them. I'll see you in the next one.